So thank you very much, actually, indeed, for inviting me. And I'm pleased to be here today on World Mental Health Day and tell you a little bit about my research, which centers around the development and also implementation of brief psychological interventions. And in this presentation, I will focus specifically on populations exposed to adversities. As Maeve just said, I focus predominantly on conflict-affected populations. So just a bit on the session structure. So specifically in this session today, I will provide a bit of background information on the topic first, and I will talk about the burden of disease when it comes to mental health problems. And I will also elaborate a bit on the prevalence and access to care at a global level before I will then talk about the systematic development and implementation of a transdiagnostic intervention that we developed that focuses specifically on alcohol misuse and associated psychological distress among conflict-affected populations in Uganda and Ukraine. So I will highlight specifically, in a way, the sort of methodological procedures that we took to develop the intervention. And that was really a participatory process with relevant stakeholders and also the local communities. And before I will then talk a little bit about implementation and also evaluation. And I will end my session today with providing a bit of an outlook, so to speak, where we need to go next as researchers and highlight also further research needs. So I'll start with provide a bit of background information on mental health at a global level. So as you may know, we have a very high burden of disease when it comes to mental disorders. And this was again confirmed by the GBD study, whose results came actually out last year. So the current estimation is that we have around 970 million cases in the world, and that reflects an almost 50% increase in cases in the last 30 years. Mental disorders are also very disabling diseases, and mental health and substance use disorders have been announced as the leading cause of disability worldwide, with depression ranking as #1. What we see in other studies, and this has also been confirmed by our own research, is that the burden can be much, much higher when it comes to vulnerable populations across the globe or populations who have been exposed to adversity. So, for example, we have estimated that 1 in 3 women who are forced migrants and who are also pregnant suffer from depression, and similar figures can also be found among Syrian refugees. So we have a very large burden of disease when it comes to mental health problems. And about 10 years ago, the WHO took action and called for the development of brief psychological interventions, or also called low-intensity psychological interventions, to sort of overcome the large burden of disease. And these low-intensity psychological interventions, which you see on the slide here, are common psychological therapies that we also receive in countries like Germany, and they contain evidence-based techniques, for example, such as cognitive behavior therapy. However, the difference is that the intervention or the active ingredient of therapy are broken down and they are simplified so that they can be delivered by lay healthcare providers. So people who do not necessarily have a health background. And the other difference is that they are reserved for people with mild or moderate symptoms of, let's say, depression or anxiety, and can be thought of as a first intervention step. And all these interventions are scalable because they are short in duration and they do not rely on the delivery of the intervention by a mental health professional. And I would say the most successful intervention of WHO is probably Problem Management Plus. You see the manual on the slide here, and that is an intervention that can address symptoms of depression, anxiety, and also psychological distress among populations who have been exposed to adversities. And its effectiveness has been established through several trials in conflict and post-conflict affected settings, and also among refugees and migrants who have resettled in Europe. It can be delivered by non-specialist helpers as well, and it has different forms of delivery. So there's an individual version, and there's also a group-based version, and it usually gets delivered in around 5 sessions, and one session is around 90 minutes in duration. The core strategies of PM Plus are, you see those on the slide here. These are strategies that can teach the client or the participants how to manage stress, how to manage their problems. So problem-solving strategies are being taught. It also incorporates strategies for behavioral activation, and that is called Get Going, Keep Going. So clients learn to take up again the activities that they usually enjoyed. And finally, it addresses also how clients or participants can strengthen their social support system. And there's also a final session that focuses how to prevent relapse. So the interventions that you have seen on the previous slide, they are all open access, and they are very successful, but at the moment there's no scalable intervention that also addresses alcohol misuse and associated psychological distress. So there's really no intervention out there that can be readily be taken up by lay healthcare providers. And this is what we want to develop as part of the Change project. And I will introduce now how we develop the intervention. So the Change project specifically seeks to develop and implement an intervention for alcohol misuse that can be delivered also by lay healthcare providers, and that it should be implementable in a humanitarian setting or in a conflict-affected setting, so a very fragile setting. And we wanted really to fill the research gap and to advance the provision of mental health interventions that can be made open access for such populations and settings. And in the Change project, we work in 2 sites, as you see here. So firstly, we'd like to implement the intervention in northern Uganda, and we are focusing here on South Sudanese refugees in the Rhino refugee settlement and also among the population in Ukraine. So we started actually preliminary work for this project back in 2018 in Ukraine, when there was a conflict in the eastern parts of Ukraine only. And initially we wanted to focus on that area only, meaning we wanted to focus on internally displaced persons. So people who got displaced from the eastern part of Ukraine, and we also wanted to include veterans. But since then, of course, the picture changed drastically, and the whole population is now conflict affected, so to speak. And we will now basically change our plans and implement among the general population in Ukraine. So back in 2018, we conducted a stakeholder workshop in Kiev in the form of a Theory of Change workshop that really showed the need for such an intervention in Ukraine. And it was initially suggested by stakeholders, by the local community, that the treatment of alcohol use disorders may need multiple intervention to address the rather syndemic nature and also different risk factors of the disease. But it also strongly showed that a brief therapy or a brief intervention would be very much needed, that can be implemented in community settings, in local spaces, as this may be less stigmatizing for people to go to. So since PM Plus is a highly effective intervention that has showed effectiveness and also cost effectiveness in several trials, our decision was then to complement PM Plus with additional strategies addressing alcohol misuse, rather than developing a new intervention from scratch. because adapting an existing intervention has also the advantage that the training manual and the program has already been established. And also alcohol misuse, as you may know, is very much associated with symptoms of depression and also anxiety that PM Plus seeks to address as well. So many of the strategies that a person with alcohol misuse and also psychological distress needs have or are already included in PM Plus. I will now outline actually how and which process we followed to develop a psychological intervention, so the change intervention, and I will elaborate a bit on how we decided actually which strategies to include into PM Plus. We followed quite a systematic process that was really participatory, and we conducted the development of the intervention together with international stakeholders, but also local stakeholders, and we also consulted the local community. And as you see here, we have used a range of methods, which I will now talk about in the next few slides. So firstly, we conducted a meta review with the aim to, in a way, firstly, identify the common elements of psychological interventions for alcohol use disorder. So we asked ourselves, what are the active ingredients and what are the common strategies of alcohol use disorder therapies that we can include in the change intervention? So we reviewed a large number of systematic reviews actually and found out that the most commonly used strategies included those implemented in the initial stages of treatment, so assessment, giving personalized feedback on drinking, and also goal setting. Those implemented while ending the treatment, focusing on prevention and relapse, and those implemented through the course of treatment. So motivation interviewing is very important, also setting and reviewing homework, and also problem-solving skills. And the more commonly used strategies were actually behavioral strategies compared to cognitive strategies, so which is a bit more difficult. So identifying and disputing distorted thoughts was less being used. So following the meta review, we conducted a Delphi survey in which we included 25 experts from Uganda, from Ukraine, and also other international experts whom we asked in a way to rate the feasibility, acceptability, and also effectiveness on all the common elements that we have identified through the meta review. So we conducted 2 rounds actually of the Delphi survey to come to a conclusion on which of the strategies are actually feasible to deliver in the settings we are working, and also which strategies may be accepted by clients or participants, and which strategies experts thought are working most effectively in their alcohol misuse. And we also wanted to explore current help and treatment seeking strategies and barriers to seeking treatment. So we wanted to know what is actually currently available and why are certain services not being used. So I brought here some results on the explanatory models in Uganda that were reported by refugees in Uganda, where we are working post-migration stressors. So pre-migration stressors included events that happened before fleeing to Uganda, such as traumatic events, including the witnessing the killing of family members, and also being separated from loved ones. Participants also described the loss they experienced as a result of the displacement. So they described the loss of their property, their homes, their jobs, sources of income they had in South Sudan. And post-migration are stressors that happened after migration, and those included being impoverished with worsening food insecurity, limited opportunities for employment, for example, and also earning an income, and the resulting inability then to provide for their families. So drinking was very much used as a means to reduce stress and thinking too much, and was just used actually to forget. And one participant said, "Stress is making me to take alcohol because I left everything in South Sudan. I'm sleeping on rags. I do not have anything at all. This causes for me overwhelming stress. I take alcohol so that I don't think about all these things." And in Ukraine, the reasons were, of course, a bit different. And please note that this data was collected before the complete Russian invasion. So in 2021, internally displaced persons from Eastern Ukraine told us that they were drinking because of the mental health problems related to the conflict. So lack of social support, losing friends, difficulties with social relationships, and also normalization of alcohol use in the community, and that it was accepted, that drinking was accepted everywhere, and also cultural traditions. And one participant mentioned to us, "I don't know, it seems to me in connection with the military actions that took place in our country, everything slowed down, everything stopped. Before, people lived for a purpose. They wanted to do something at home, or maybe they had some work. When all this happened, the conflict, everyone stopped believing in this village. Everyone stopped planning. Everyone here became so gloomy." So following the meta-review and the Delphi study and also the qualitative interviews, we then conducted 3 treatment development workshops in which around 25 experts in each workshop assembled all the information that was collected until then. So the strategies from the meta-review, the Delphi study, and also the results from the qualitative interviews into a coherent treatment. And they identified in a way the theoretical foundation for the treatment. So ranking, pile sorting, and also scheduling methods were employed to finalize the list of strategies and organize them into related groups and schedule them into a coherent treatment delivery. So at that workshop, we decided then which strategies would go into the change intervention and in which session. And we conducted 2 treatment development workshops in English and 1 treatment development workshop in Ukrainian. And finally, we also conducted a theory of change workshop held in both sides to inform barriers and also facilitators of implementation and also delivery of the change intervention. So we have done 2 theory of change workshops in Kiev and 1 theory of change workshop in Kampala and also in the Rhino camp respectively. And all of that strategies helped us to, all of these methods I've just outlined helped us to develop a first draft of the manual. And here you can see some pictures of the theory of change workshop in which we discussed also the potential implementation barriers of the intervention and ways or strategies to overcome them. We then developed the first draft of our intervention, and the overall aim of the change intervention is to reduce alcohol misuse by, in a way, enhancing a client's motivation to change their behavior and also to reduce the problems that they identify as being of concern to them. And the overall approach of the change intervention involves problem management in addition to selected behavioral strategies for dealing with drinking problems, such as motivation interviewing skills, managing emotions, identifying high-risk situations for drinking, just to provide a few examples. And in combining these strategies together, the program really aims to address the highly interrelated psychological problems. So stress, fear, feeling of helplessness, alcohol misuse, and where also possible practical problems, so conflict in the family people may have. And the intervention takes place over 5 to 6 sessions, and all sessions are individual. So I will now say a little bit about implementation and the anticipated evaluation of the change intervention. And I will predominantly actually talk about the Uganda side, as we had to stop the work in Ukraine for some time because of the war. So our main implementation strategy is actually training of lay healthcare providers in Uganda, comprised a classroom-based training in which the content of the intervention and also basic therapist skills were being taught. And this was then followed by an internship period in which lay providers had to take on real clients to practice the intervention for a couple of weeks. And in total, we trained 17 facilitators in the intervention. We have 5 male and 12 female counselors, and their mean age is around 33 years, and they have all a bachelor degree, but covering different subjects. So from education to management, but none of them have experience in delivering mental health interventions. So the clients or participants of the change intervention, they are actually recruited by household recruitment. So our research assistants, they have to go to the several villages of the camp area to recruit participants, and they have to screen them. And we included them in our study if they have an alcohol misuse audit score from 8 to 19 and show high levels of psychological distress. We did not include women, since the prevalence of alcohol misuse among women in this setting is actually very low, so it's not existing. We also excluded participants who showed signs of alcohol dependence, as the intervention is not really designed to address alcohol dependence. And we also excluded participants who have obviously a high suicide risk, who suffer from severe mental disorders, and also who show signs of cognitive impairment, so that they can't follow the intervention. So after the training and the internship period, we adapted the intervention manual, and we conducted a treatment cohort in which we recruited 20 participants and conducted, again, qualitative interviews after each session with participants to sort of hear and get their insights on the relevance, acceptability, and also feasibility of delivery for each session. We had surprisingly 20% dropouts, which is comparable to other psychological interventions that we conducted. And lessons that we learned during this exercise was that clients liked to have some compensation for the attendance of session. So we have now provided some refreshments during intervention delivery, and facilitators found some strategies to be more difficult to deliver than others. So we have given additional training. So after the treatment cohort, we conducted a pilot RCT to test feasibility of delivery, the acceptability of the intervention, and importantly, of course, the methodological procedures. So recruitment, randomization prior of the definite RCT. The intervention group received the change intervention, plus, as I've just outlined, in addition to enhanced usual care, and the control group received enhanced usual care only. So all participants have received enhanced usual care following baseline assessment, and this comprised a one-page information sheet detailing available resources in the community, and information on reducing alcohol intake and managing psychological distress within the settlement. And this has been delivered by a member of the village health team. So for the pilot RCT, you can see some figures here. We have included 30 participants in the intervention, and we have similar figures in the control group. We had a very low dropout, which is encouraging, and no serious adverse events that could be related to the intervention. And we finished the pilot in spring this year. So for our timeline, we started the definite RCT, for which we need to recruit 500 men in August. And we also will explore scaling up, and we will investigate what influences scalability of the intervention from next year onwards. And we hope that data will be ready to be analyzed in 2024. So we initially, as you may remember, we initially designed the project to be conducted in Uganda and also in Ukraine. But because of the war, we had to stop for some time. And part of our initial team has also fled Ukraine, but the core team is still there, and they are very keen to resume the work because of a high need also in the population. So we have now trained our trainers and providers online and also face-to-face. The situation is obviously very different to what we had initially. And we have measures in place to protect our staff and also the participants. We are also considering online delivery of the intervention in addition to face-to-face. And this is similar to what we plan for outcome assessment. And following all of our preparatory work in the last few months, we have just now resumed our initial planned work, and we have started with the pilot RCT. So what we hope to achieve in change is the following. So we hope that our intervention is effective in reducing alcohol misuse, and that it also has an effect on psychological distress. Because if it does, we will make our intervention open access so that it can be used by other communities and in other settings where there's a high need. We also have a training manual that outlines how training should look like for master trainers and for lay healthcare providers. And finally, through implementation of the intervention in two very diverse settings, we also hope to increase our understanding on the working mechanisms and the barriers to care, and learn about strategies to overcome them. That can be hopefully translated to other complex settings in which people need support. And through our work package on scaling up, we also hope to learn about new ways in which the intervention can be integrated and also scaled up in the health system and other humanitarian settings. So in this session, I have outlined what brief psychological interventions are. I've talked about the methods that we took to develop them, and I've outlined how they can support different population groups and also communities for better mental health. And I believe that these kinds of interventions have a real potential to tackle the large burden of disease that we see across the globe, even in countries that enjoy a good functional health system. Because even in countries like Germany, for example, access to mental health care can be a postcode lottery. And it's depending where you live. Depending where you live, you may need to wait much longer for mental health care. And therefore, these kinds of interventions may also be applicable to high-income countries, and they have already been successfully implemented in Europe. However, in order to make wider implementation of them a reality, we have quite a few implementation hurdles to tackle that may require procedural changes of our health system and changes in how health care is delivered to whom and where. So all of that, what I've presented today, would not have been possible, of course, without our fabulous partners that are Health Right International, the National University of Kiev, the London School of Hygiene and Tropical Medicine, and the University of Copenhagen. And of course, we are also grateful to our funder who supports this important work. On this slide here, I've added references that you may find interesting. And the GLOHRA team also asked me to share my understanding of global health research, which I included here on this slide as well. So I thank you very much for listening. Thank you very much for attending. I hope you enjoyed it, and I'm looking forward to your questions. Thank you very much.